Appreciate that. Thank you all. And I'm now going to move us to our third panel. So big panel. We have six papers in this issue, all that focus on the topic of homelessness or housing instability. It is a critical dimension of the relationship between housing and health. It has some similarities, but also some real differences from some of the topics we've been discussing. So we thought it was important to give it its own panel that's going to cover a lot of different topics, and then we'll try to bring some of it together toward the end. I'm going to introduce our panelists, and then we'll turn to them sequentially to present. Cheyenne Garcia from the University of California, San Francisco, who's going to present the overview paper on homelessness in this issue. Matthew Fowle from the University of Pennsylvania around mortality among the homeless population. W. David Bradford at the University of Georgia, looking at another dimension of mortality, particularly drug and alcohol related. Michael Mayer at the Boston Medical Center, talking about clearing homeless encampments and the perspectives of residents when that occurred. Devlin Hanson from the Urban Institute, talking about the effects of the housing first approach on psychiatric care. And Hannah Decker from UC San Francisco, looking at cancer outcomes for unhoused veterans. So many different topics, but all important dimensions of the effects and the relationship between homelessness and health. Cheyenne, I'll turn over first to you.
Hello, everyone. I'm Cheyenne. I am a researcher at UCSF, the Benioff Homelessness and Housing Initiative. And today I am going to discuss our overview of homelessness and health. Next slide. So the first thing to know is that poor health and homelessness are bidirectionally associated with one another, which means that poor health increases an individual's risk of experiencing homelessness, and homelessness worsens people's health. And so this is shown in a variety of ways. Poor health can increase a person's risk of homelessness through direct and indirect mechanisms. For instance, poor physical health can interfere with occupational attainment, and medical debt has been shown to deplete people's savings. Mental health and substance use disorders interfere not only with occupational attainment, they also worsen social relationships and can lead to involvement with the criminal justice system, both of which increase an individual's risk of experiencing homelessness. Homelessness also worsens an individual's health through direct and indirect mechanisms, such as exposure to violence and unintentional injuries, and the environmental conditions of crowded shelters and exposure to the elements in unsheltered settings. Homelessness also interferes with the receipt of longitudinal health care and substance use treatment. And people experiencing homelessness have worse physical and mental health, experience accelerated aging, and have higher rates of age-adjusted mortality than those who are housed. Next slide. And healthcare systems should optimize their care for patients experiencing homelessness by employing evidence-based strategies for care. And providers should identify community resources in order to provide appropriate referrals for their patients experiencing homelessness. In our paper, we highlight 4 evidence-based practices. The first is really based on expert opinion. We recommend the use of low barrier care. This is a flexible care model specifically for patients experiencing homelessness that can be characterized by flexible scheduling, simple medication regimens, and also being able to use trauma-informed care. Second is an evidence-based intervention called critical time interventions. These are stepped, time-limited interventions for those who are exiting institutional settings, and their aim is really to prevent homelessness in this vulnerable population. The third is social needs screening, which is screening that providers can do for social determinants of health. That can include housing insecurity and homelessness. And it's really done in order to do 2 things. First, tailor medical care, and second, to connect individuals to their community resources. Finally, we recommend the evidence-based practice of medical respite, also called recuperative care. And those are really 24/7 shelters with meals and basic medical care and social services that are available to people who are experiencing homelessness who are discharged from the hospital because they no longer meet criteria for hospitalization, but they're too sick to be discharged to the streets. Next slide. And the most important takeaway of the talk, I think, is that the solution to homelessness really does lie outside of the healthcare system. Ending homelessness requires that we invest in evidence-based solutions that can be supported by the healthcare system. And the gold standard evidence-based practice to end homelessness is housing first. Housing first is both a principal and a flexible housing model that provides housing without the requirement of sobriety or employment. It's most often implemented as permanent supportive housing, which is subsidized housing with voluntary supportive services. And multiple randomized controlled trials across the US, Canada, Europe have shown that permanent supportive housing successfully houses people with chronic homelessness and substance use or mental health problems. Next slide. With this evidence in mind, we present several policy recommendations. The first is we recommend an increased use of Medicaid to fund housing-related services. And the mechanism through which this can be done is the Medicaid Section 1115 waivers. So several states, as you heard a little bit earlier, North Carolina is one of them, California, Oregon, and Arizona are other states that have received these waivers to provide Medicaid coverage for housing adjacent services, such as housing navigation, case management, and funds for moving costs. And several states have received these waivers to improve care for those transitioning from institutional settings. For instance, Arizona uses an 1115 waiver to fund Medicaid coverage for individuals before prison discharge, and Illinois has applied to do the same. Oregon uses Medicaid funding to pay for transitional housing after institutional care. If you could go forward, thank you. Next, we recommend increasing the availability of permanent supportive housing, which again is subsidized housing with voluntary supportive services. And healthcare systems really have an important role to play by providing these services, including physical and mental health care. And next slide, there, yeah. And finally, we recommend that we increase the supply of deeply affordable housing, and this can be done through multiple mechanisms. It can be done through zoning reform, increasing the availability of housing choice vouchers, increasing the availability and flexibility of the low-income housing tax credit, and finally, enforcement of anti-discrimination laws, especially those around source of income discrimination for voucher holders. Next slide. Thank you. Appreciate it.
Good afternoon, everyone. My name is Matt Fowle. I'm a postdoctoral fellow at the University of Pennsylvania, working at the Housing Initiative at Penn. I'm really pleased to be able to present the study that Dr. Giselle Ruthier, assistant professor at New York University, and I conducted on the rise in mortality among people experiencing homelessness, which we ascribe to mortal systemic exclusion. By what percent has the homeless mortality rate increased over the last decade? This question has been difficult to answer because no federal agency records or collects nationwide data on mortality among people experiencing homelessness. Therefore, we built a national data set of individual level death records for people experiencing homelessness, obtained from medical examiners, coroners, sheriff's offices, and public health departments. The final dataset contains information for more than 22,000 homeless decedents across 22 localities in 10 US states and the District of Columbia over a 10-year period. And I'd like to share our key findings with you. In answer to, back one slide, please. In answer to my opening question, we found an unprecedented 238% increase in the all-cause mortality rate among people experiencing homelessness between 2011 and 2020. And this resulted in a 2020 homeless mortality rate that was 3 times larger than the rate for the general population. Next slide, please. What's driving this rise in mortality? Drug and alcohol overdose, cardiovascular disease, unintentional injuries, traffic injuries, suicide, and homicide are the 6 primary causes of death. We also found cause-specific mortality rates due to hot and cold exposures increased by 141%, cancers increased by 320%, and diabetes and infections increased by more than 400% each. The circumstances in which these deaths occur are tragic, yet preventable. Next slide, please. Our findings present evidence of the widespread worsening of homeless mortality across the United States, particularly among the causes that are preventable with access to stable housing and appropriate healthcare. At the most fundamental level, housing provides protection against exposure to the elements and to violence. Housing also provides a stable platform that supports gaining employment and education and establishing regular access to healthcare. Without housing, it is extremely difficult to consistently engage with medical services, such as routine healthcare that can identify the onset of serious medical conditions like cancer and heart disease, or manage chronic diseases like diabetes, or address mental illnesses and substance use disorders. Next slide, please. To address rapidly rising mortality, we highlight the strong need for state and federal intervention to ensure that cities and counties track standardized data on homeless mortality. There must be a nationwide database that tracks all cause and cause-specific mortality rates, changes in trends over time, and our progress towards eliminating homeless deaths. The most effective form of mortality prevention is in preventing the occurrence of homelessness in the first place, and in rehousing people experiencing homelessness as quickly and stably as possible. Governments must ensure that people experiencing homelessness are systematically incorporated into the life-affirming institutions of affordable housing and healthcare. Thank you very much for the opportunity to share the highlights of our research with you.
Thank you very much for the invitation to come today. I'm going to take a slightly different tack and not use slides to try to minimize some of the transition time. So on behalf of my co-author, Felipe Lozano Roja, I want to thank Health Affairs first for hosting this webinar to introduce various papers that are in this special issue on housing and health. And, we're very pleased to be able to give you an overview of our contribution, which is titled Higher Rates of Homelessness Are Associated with Increases in Mortality from Accidental Drug and Alcohol Poisonings. Now, you've already heard wonderful introductions to this long-standing problem of housing instability in the United States, and I suspect everyone is broadly aware of the crises surrounding deaths of despair, like opioid poisoning. So I'm just going to jump right into what it is that Felipe and I were trying to understand. So the work that Felipe and I undertook examines the intersections of these two long-standing crises. Specifically, we wanted to know whether and how homelessness causally drives ongoing deaths of despair, particularly around substances, opioids, and alcohol as sort of the primary sort of top-line results we'll be talking about. Now, both of these problems, housing instability and substance-related mortality, are persistent, and they show no signs of relenting. There's some prior work on in this area conducted by Ashley Bradford, who you'll be hearing in the next panel, and myself, that found a causal link between evictions and opioid and alcohol deaths. However, to date, there's not been a similar study to identify a link between the most extreme form of housing instability, homelessness, which we've just heard about in the last two papers in this panel, and the sort of mortality that leads to deaths that are sort of classified as deaths of despair. So that's the project that Felipe and I undertook for this paper. Now, we base our study on two main data sets. They're publicly available. You can go download them yourself and have fun with them. The first are point-in-time estimates of homelessness that are constructed annually by the Department of Housing and Urban Development. Now, HUD has divided every community in the United States into aggregations of responsible zones for homelessness services called continuity of care units. There's about 400 or so of those in the U.S. this year. We focus our analysis on the more compact metropolitan continuity of care units and exclude broad geographic regions like rest of state that may be very diverse geographically and socioeconomically. The way that this data is constructed is that on a single night in January every year, towards the end of January, these local COCs send out an army of volunteers to count every homeless person in their regions. These are called the point-in-time estimates. They're really censuses of data, and we recover that data from 2007 to 2017. It's interesting data. The difficulty with it, of course, is it's at the COC level, the definitions of which change. Sometimes counties are in one versus another. So the first step in our analysis turned out to be a crash course in constructing harmonized shapefiles and geocoding the data. But in the end, we were able to link every county in the United States to the COC that they happen to be in each year. Which takes us to the second data set we used, which is much more straightforward, the CDC multiple cause of death microfiles. This is essentially an abstract from every death certificate in the United States, about 2 to 3 million deaths in the US each year. We extracted information on deaths with any cause listed for a number of substances, any opioid, prescription opioids, that is the natural and semi-synthetic opioids, synthetic opioids like fentanyl, heroin, stimulants, benzodiazepines, cocaine, and alcohol. All of that was aggregated up to the COC level. And that forms the basis of our analysis. Now, our primary analysis is trying to understand or model the number of deaths in each COC for each of these categories separately of mortality as a function of the primary variable of interest being the homelessness rates. But as you saw in the first paper of this panel, there is this concern about sort of bidirectionality in the relationship between homelessness and health outcomes like substance use disorders that lead to substance-related deaths. And we wanted to be able to say something about causality. And so we needed to have a statistical method that eliminated that potential for a feedback. So we used a form of instrumental variables called two-stage residual inclusion. I won't go into any of the details. If you're interested, email me. I'm happy to go on at great length about it privately. We followed the work that Bradford and Bradford in 2023 and used a panel of state landlord-tenant laws to predict homelessness outcomes, with the pathway being landlord-tenant laws affect evictions, which we've already seen. Evictions affect homelessness, but those laws don't themselves have a direct impact on mortality. We do the usual tests for instrumental variables. There's the weak tests and a more recent contribution by Emily Oster to help us understand whether we've purged omitted variables bias from the analysis, and everything passed. So we're feeling confident that we at least have a basis for making causal claims about the impact of homelessness on these mortalities. So once we have all of that done and we're prepared, we then run these the models of the number of deaths using sort of a binomial generalized linear model as a function of these instrumented homelessness rates. And for the techies out there, we bootstrapped the standard errors and did all the usual stuff you do in these circumstances. Now, what do we find? So I'll express our findings in sort of percent terms so that we can compare across different kinds of substances. So what we found was that if there was a 10% increase in the overall homelessness rate, we would predict a 3.2% increase in the all opioid or any opioid mortality rate. That same 10% increase in homelessness would also be associated or predict a 5% increase in synthetic opioid deaths. That's fentanyl primarily. It would predict a 3.9% increase in heroin deaths and a 5.6% increase in alcohol poisonings. Now, we ran a lot of models using different measures of homelessness: all homelessness, chronic homelessness, sheltered homelessness, unsheltered homelessness. So there's a lot of different tables. There's a lot of parameters in the paper if you read it. All of them, however, find the same strong, very statistically significant result that shows a positive relationship. More homelessness translates into greater levels of substance, basically whichever substance we look at and whatever measure of homelessness we have. If we wanted to put this in other terms, if we were to take every county in 2017, assume it was at the 75th percentile, drop it down to the median of homelessness, we think we would save somewhere around 1,960 lives just from the opioid deaths alone. So the upshot of all of this is that homelessness and deaths of despair are tightly linked, and making progress from a policy standpoint on homelessness actually has the add-on benefit of helping us make progress on the substance-related mortality epidemic as well. So we hope that policymakers can take that into consideration when they're doing their internal cost-benefit analyses. Thank you very much.
Great.
Great, thank you so much. Thank you for the opportunity to be here. And I'm going to continue the trend of presenting without slides for the sake of time here. My name is Mike Mayer. I'm a medical student at Stanford, and I formerly worked as a housing program manager at Boston Healthcare for the Homeless program and as a research assistant at Boston Medical Center. I'm excited to talk to everyone about our paper today. Our paper is Encampment Clearings and Transitional Housing, a Qualitative Analysis of Resident Experiences. Cities across the country, including Boston, have debated how best to address tenant encampments, which can sometimes be sites of substance use and violence, in addition to being very visible evidence of homelessness. Encampment sweeps, which is the removal of tents and dispersal of individuals who are staying there, is a common policy approach. However, modeling studies and other data suggest that these interventions lead to increased risk for overdose death and harms for people living in encampments. They're also an aggressive approach to addressing homelessness that contribute to multiple layers of dehumanization and trauma brought upon people experiencing homelessness by our social safety nets and as well as our carceral system. In 2022, the city of Boston conducted an encampment clearing paired with a novel intervention, low threshold harm reduction housing spaces for displaced encampment residents. These harm reduction housing sites consisted of repurposed hotels, shelters, and healthcare facilities. They used a harm reduction model that provided wraparound healthcare and access to social services and offered guests significantly more autonomy compared to traditional emergency shelters. Guests were given their own rooms. They were allowed to come and go as they pleased. While many displaced encampment residents were able to access these harm reduction housing sites, unfortunately, some individuals were missed and were instead displaced to other unsheltered living arrangements throughout the city. So to answer the question of how tent encampment removal and harm reduction housing actually affect the health, safety, and substance use outcomes, the things that policymakers often are most concerned about, we recruited 30 participants who previously lived at the cleared encampment and conducted interviews with them. Of the 30 participants, 14 had been placed in harm reduction housing and 16 had not. We found that harm reduction housing improved the health and safety concerns for nearly all admitted participants. Many of the participants felt they had made meaningful progress toward long-term stability, including achieving employment, making significant progress toward permanent housing, and initiating therapies related to chronic health conditions and addiction. These steps were largely attributed to the structure of harm reduction housing itself and the trauma-informed staff hired to support the residents. Having their own room meant participants could keep belongings safe for extended periods. It meant providers and case managers could follow up with them readily on healthcare needs and connection to additional services. Being able to live with one's long-term partner meant participants actually enjoyed living in harm reduction housing, leading to extremely high retention and care rates. Being able to come and go as they needed meant people could pursue other needs related to recovery and social support without the constraints of traditional shelters. And finally, the trauma-informed staffing and the frequent checking in conducted by harm reduction specialists on site meant participants felt safe and supported to pursue recovery on their own terms. For participants who were not admitted to harm reduction housing, the disruption of social ties via displacement generally exacerbated health and safety concerns that we know are already associated with unsheltered homelessness. These concerns, including assaults, loss of belongings, and exacerbation of mental health conditions, lasted well beyond participants' immediate displacements. Individuals shared that the stress induced by the encampment clearing was overwhelming. Some participants shared it made them suicidal, and one shared it led them to requiring an inpatient hospitalization. Some participants shared that their substance use increased markedly after the sweep. They needed a way to cope with the stress of losing their belongings, of losing their community, and losing their homes. Safety concerns were a major theme that came up in our interviews. Despite the violence that can sometimes be associated with encampment settings, participants felt that there was at least some form of order and stability in these settings, created and enforced by the community itself. The encampment clearing just fully disrupted this. The clearing led to an influx of new people to the area. Participants described these newcomers as not knowing the quote unquote rules of the space and as frequently fighting for territory or social status in the area. The clearing also disrupted social networks that many felt were crucial for their day-to-day survival. This disruption was especially significant for women and gender oppressed individuals who frequently cited friends and neighbors as being crucial to their safety during the night while living on the streets. Though health and safety concerns in encampments were acknowledged by all participants, encampments were consistently raised as a better alternative to traditional emergency shelters, suggesting a dire need for improvements to our shelter models and other structured service environments. Namely, the shelters were frequently described as environments that limited autonomy, limited privacy, and created difficult social interactions between both guests and staff. They were described as traumatizing for people living with multifaceted trauma, especially people with incarceration histories. In some cases, shelters were fundamentally inaccessible for people, for example, for people with long-term partners or people with addiction to fentanyl. Our findings suggest first that encampment clearings or sweeps as they exist today are both ineffective in improving health and safety concerns for encampment residents and are traumatizing and dehumanizing for people living through these clearings. Sudden disruption of encampment communities is unlikely to be a helpful intervention and may instead heighten health and safety risks for people living in the neighborhood. Instead, we recommend a gradual intervention that provides low threshold harm reduction, shelter and housing access, and that allows residents to enter shelter and housing on their own terms and on their own timelines. Our findings also suggest that low threshold harm reduction housing is an effective model for improving health and safety outcomes for people in encampment settings, suggesting improvements that could be made to traditional emergency shelters. Many participants shared that they had found part-time employment and were already excited to expand this. And this was only weeks or months after moving from an encampment setting. The harm reduction housing model we investigated was particularly successful due to its structural protection of autonomy and privacy for guests, its on-site access to services, and its trauma-informed non-judgmental staff. Changes to traditional shelters that promote autonomy, privacy, stability in the form of a consistent bed, access to adequate storage spaces, and hiring of trauma-informed staffing, especially peer specialists, are likely to make shelters more accessible for people with addiction and people who otherwise would be forced to live in encampments. Finally, our findings suggest that in lieu of structural change to traditional emergency shelters and large-scale investment in harm reduction transitional housing models that work, other interventions such as outreach-based care and safe injection sites may be able to mimic the benefits of encampment living without the associated risks. And that's all I'll share for today, but thank you so much.
Hi, my name is Devlin Hanson, and I'm an economist at the Urban Institute. Together with my co-author, Sarah Gillespie, we wrote the article, Housing First, Increased Psychiatric Care Office Visits and Prescriptions While Reducing Emergency Visits. Next slide. Homelessness remains an urgent public health concern, particularly for people who endure chronic homelessness and have high rates of mental health and substance use disorders. In 2022, federal data showed the highest total number of people experiencing homelessness and the highest number of people experiencing chronic homelessness since data collection began in 2007. Evidence has been mounting on the effectiveness of permanent supportive housing for outcomes such as housing retention and reductions in jail time, but rigorous evidence on its impacts on healthcare use has been mixed. Housing First is an approach to ending homelessness that recognizes housing as a platform for stability and engagement in health services. Next slide. In 2016, the City and County of Denver, Colorado launched the Denver Supportive Housing Social Impact Bond Initiative. A supportive housing intervention designed to serve a chronically homeless population that had frequent arrests and jail stays. The project provided 250 project-based or scattered site vouchers. The program was implemented using a housing first model. Consistent with the housing first model, those in the program were not subject to any conditions of participation to be eligible for or receive permanent supportive housing through the Denver SIB. People in the intervention group who received housing were housed in either a scattered site unit rented with a housing subsidy in the private rental market or a single site building fully dedicated to supportive housing units. Supportive housing providers used a modified assertive community treatment or ACT model under which participants received comprehensive care from multidisciplinary teams. Other core components of the ACT model are small shared caseloads among all ACT team providers and delivery of nursing and psychiatric services in participants' home with no time limits on service eligibility. Next slide. To measure the impact of the Denver Supportive Housing Program, we implemented a randomized controlled trial. Specifically, we randomized 724 individuals on a rolling basis from 2016 to 2017. Those assigned to the intervention were referred to the housing providers to receive supportive housing. Those randomized to the control group received services as usual in the community. Two of the outcomes we looked at, healthcare utilization and Medicaid enrollment, were measured with administrative data from Medicaid. And the third outcome, mortality, was measured using vital statistics data. Next slide. In all of our analysis, we ran regressions which controlled for pre-randomization characteristics. Although we do not see any statistically significant differences in office-based care visits, overall, we do see 8 more office-based care visits with a primary psychiatric diagnosis. On average, the intervention group had 8 more office-based care visits compared to the control group in the 2 years after randomization. Next slide. We also found that the intervention had significant impacts on emergency department visits, the number of medications that were prescribed, as well as the number of other services that were received. We find that the intervention group had 6 fewer emergency department visits than the control group in the 2 years after randomization. The intervention group also had 3 more prescription medications prescribed and 12 more other services than the control group in the 2 years after randomization. We found no significant difference in the number of ambulance trips between the 2 groups. Next slide. When looking at the share of individuals who had any visit with a specific diagnosis, we found that the intervention had a significant impact on the share of individuals who received any service with a mental health diagnosis. Specifically, we found that those in the intervention group were 34 percentage points more likely to receive any service with a mental health diagnosis compared to the control group in the 2 years post-randomization. This is particularly true for diagnoses related to anxiety, psychotic disorders, and PTSD. We found no significant differences in receiving services with a substance use diagnosis or a physical health diagnosis. Next slide. We found that those in the intervention group were actually less likely to be enrolled in Medicaid in the 2 years post-randomization compared to the control group. Although the share of individuals enrolled in Medicaid rose over time for both the intervention and control group, the intervention group was 5 percentage points less likely to be enrolled in Medicaid compared to the control group in the 2 years post-randomization. This translates to on average 1 less month being enrolled in Medicaid for the intervention group compared to the control group. When we look at whether they received any services, we do not see any statistically significant difference between the intervention and control group. We also looked at the impact of the program on mortality and found that there was no statistically significant difference between the intervention and control group. Next slide. Our study shows that supportive permanent housing, and specifically a housing first model, impact healthcare use by reducing emergency department visits and increasing office-based care visits with psychiatric diagnoses, as well as medications. Even though housing first does not require participation in services, healthcare use was higher in this group than in usual care in terms of office-based care visits with psychiatric diagnoses. Not only is permanent supportive housing a housing intervention, but it is also an intervention that facilitates healthcare services for people with many healthcare needs. Policymakers should consider the impact on healthcare use when considering pathways to scale permanent supportive housing. Next slide. Thank you very much.
Hi, everyone. My name's Hannah Decker, and I'm a general surgeon in training at UCSF, working with the Benioff Homelessness and Housing Initiative. And I'm so grateful for the opportunity to share a little bit with you all about what we found in our article, Changes in Housing Status Are Associated with Cancer Outcomes in U.S. Veterans. Now, to give some very brief background, the homeless population in the U.S. is aging. Nearly half of single unhoused adults are over 50 years old, which is the age when cancer incidence increases and national guidelines recommend screening for certain cancers. In fact, as we've heard today, cancer is a leading cause of death in unhoused adults. And there is evidence that unhoused patients have higher risks of death than housed patients following cancer diagnosis. But we don't really know how this maps to changes in housing status. For example, if an unhoused person gains housing after diagnosis with cancer, does that change their survival? To answer this question, we examined over 100,000 veterans diagnosed with lung, colorectal, or breast cancer from 2011 to 2020 who received care at the VA. At the time of diagnosis, 95% were housed, and 1% of these veterans lost their housing in the year after diagnosis. 5% of our total cohort were unhoused. Just over 20% of these veterans actually gained housing in the year after diagnosis. So this left us with 4 major groups: continuously housed, continuously unhoused, those who gained housing, and those who lost housing. And we were able to really carefully assess housing status each month for the year before and the year after cancer diagnosis, because the VA does a really thorough job, as we've heard from other presenters, of systematically documenting housing status. So we use clinic reminders, diagnosis codes, and other screening information from the medical record, which helps us really get a fine-tuned assessment of how not just housing status, but housing status changes around the time of diagnosis. Next slide, please. Again, our main research question was, are changes in housing status after cancer diagnosis associated with survival? And what we found is yes. When compared to continuously housed veterans, both continuously unhoused veterans and veterans who lost their housing after diagnosis had worse overall survival after diagnosis with lung and colorectal cancer. And this was true even after adjusting for variables that were different between the two groups. Between the groups, including stage at diagnosis and other demographic variables. Continuously unhoused veterans had between a 9 and 22% higher risk of death, and veterans who lost their housing after diagnosis had between an 18 and 29% higher risk of death than continuously housed veterans. But the group of veterans who were unhoused at the time of diagnosis, but gained housing in the year afterwards, actually had no difference in survival from housed patients. And this suggests to us that gaining housing after cancer diagnosis is associated with a survival benefit. Now, this study does have some limitations. Most significantly, we were only able to study veterans who are enrolled to receive care from the VA. And because the VA provides universal health care to its beneficiaries, this setting effectively eliminates insurance access as an issue for unhoused patients. This means that our analysis likely underestimates the association between homelessness and poor health outcomes after cancer diagnosis. Next slide, please. So thinking about the implications of this, what we found is that housing is associated with a survival benefit compared to remaining homeless after cancer diagnosis. And there are several potential mechanisms for why this might be the case. First, stable housing might help patients alter health-related behaviors that might contribute to improved overall cancer outcomes. Stable housing might facilitate coordination of complex cancer care by reducing things like competing priorities, vulnerability to external forces, and by improving access to consistent communication and schedule of outpatient care. And this might improve outcomes. And then finally, gaining housing in this setting is likely also a surrogate measure for additional supportive care, including caregivers, social support, access to transportation, and support for appointments, which veterans can get through the VA. But in sum, our research suggests that policies to promote housing and prevent homelessness might improve cancer-related outcomes. Next slide. Thank you.
Okay, thanks to all of you for just an incredible collection of research. Obviously, you touched on very different dimensions of the issue, and so there's not sort of a single thread, but I do want to return, Cheyenne, to where you started with a sort of unabashed call for housing first. And as I listen to presentation after presentation showing health effects associated with homelessness and improvements with obtaining housing, it does seem that if you're sitting over on the health side of the world, I don't know how many of you count yourself as housing experts, but I do not. If you would say, if you're sitting in the health part of the world, housing first is the place to begin. And so I'd be curious if others agree with that sentiment. And if so, how far away it seems to me we are from that as sort of the general attitude towards housing, and some comments on what the health sector's role is in trying to bring about some of the changes that might be important to improve people's health. I know it's a very broad question, but be interested in additional thoughts on this. Hannah, go ahead.
I'd love to jump in. Thanks so much for the question. I think that one thing that we found particularly striking in our research is that over 20% of unhoused veterans with a cancer diagnosis gained housing in the year after diagnosis in the VA. And so to your question about how close we are to adopting housing first principles and actually promoting housing for patients, I think that the VA is one system to really look to. And I know we've heard from other presenters referencing projects and programs from the VA that really support unhoused veterans, but you know that they've made addressing homelessness a federal priority since 2009, and that's all of their efforts have resulted in a 45% reduction in the rates of homeless veterans. And so I think that one thing that gives me a lot of hope in doing this research is looking to health systems that are doing some things really right. And I'm not saying that there isn't room to adapt and grow, but I think that's particularly interesting. And you can see, you know, in our research, the real health benefit likely of those of that focus and of the work that they've been doing.
Other thoughts on this? I am struck. Yeah, go ahead, Michael.
Oh, I'm sorry. I was going to say our investigation was quite as close as you can get to a housing first model, and was just absolutely shocked by how effective the intervention was, even as somebody who's worked in the housing space for several years. Like I've said in the podcast that we've done, I have a natural skepticism of novel interventions. But you know, for people who have been living in an encampment setting, struggling with serious addiction, moving into housing, and then within a matter of weeks are looking at part-time employment, making serious progress on housing applications, it's just remarkable. So 100% housing has to be step one.
And if I could just jump in quickly and say, you know, there's a lot of movement among the accountable care organizations in this country to have sort of a broad view of what healthcare provision is, and they're investing in things like educational opportunities and in housing. And I think one of the lessons that we take from all of the work that was presented in this panel is that to the extent that those organizations do invest in housing, it actually is saving them in expenses on a variety of healthcare costs that they could then reallocate to other urgent needs. And so there is an opportunity for a sort of real economies to be had here with complementarity in the investment.
Michael, I'm glad you mentioned the podcast. I was going to too. We had a nice conversation about your paper. And one of the things I was struck by in our discussion is that there is such an outside-inside difference here that from the city's perspective, they're looking at a tent encampment and they see blight and disadvantage and drug use, and not that there aren't real harms to living that way relative to other circumstances, but there are also just tremendous benefits from being in a community that are probably completely invisible to people outside. And Hannah, I was just thinking in your response, part of what the political motivation is a defined population that people can relate to. So I'm wondering if, again, just sort of thinking about the ways in which we can begin to think differently about this issue and the population and the needs of the population. They feel very different in a setting like this than they do in sort of the general media, which is a common enough problem. I don't know if others have thoughts about that. I am moving maybe a little bit away from politics. We did hear in earlier panels about the role of housing and neighborhood quality. And one of the questions I've had throughout all of our work on this issue is that we do have the 6 of you looking at homelessness, and the last panel will look some at housing quality and affordability. But to what degree are we looking at one? Are we looking at separate issues, community, neighborhood, housing quality, and homelessness, or are they really one issue? And the degree to which, again, in the work that you've done, you feel like these are sort of 2 ends of the same spectrum, or is being unhoused sort of a qualitatively different status that requires a qualitatively different set of interventions? Anyone have a thought on?
I think something that comes to mind when you ask that is that homelessness is really something that's time varying. It's not as though someone is like homeless and then they stay homeless for years and years. For many people, it's a brief experience, and cycling between this insecure housing or kind of housing that might be suboptimal, I guess, for many health outcomes is something that I think people will go through across their life course if they experience homelessness. And it really is, I think, on a spectrum that I feel is very related to one another.
I appreciate you raising that. Actually, the narrative matters piece in this issue, which is a first-person narrative, is by a person who had that experience and is not in that status anymore, and talks about what it took to make the change and the implications of that on their life. It's a very powerful piece. So very important to see this as a continuum.
Can I add to that?
Please.
Yeah, I certainly agree with Cheyenne that it very much lies on a continuum. You know, any efforts to improve housing quality, to make somebody less housing insecure, is going to have effects on homelessness, reducing the chance that they experience homelessness in the first place. But also say, just going back to the first question you asked about what healthcare providers can do, I don't think it should necessarily be the job of healthcare institutions to provide housing. And I don't think solely private actors and organizations can solve our problem of the shortage of affordable housing. It's a state and federal problem ultimately, and I think that it has to be massive federal investment in affordable housing. I think also in social housing, which we haven't discussed very much. And I'd also just add, with regard to kind of the interventions that we're implementing that we know are evidence-based, like permanent supportive housing, we have growing levels of chronic homelessness in rural areas where we don't have the same quality of housing, we don't have the same availability of supportive services. So I think it's important that we also think beyond major cities and how these interventions are being implemented elsewhere.
Hannah, you mentioned in studying cancer, the aging population of people experiencing housing. We did get a question in from the audience earlier about just sort of in general, as people are looking at housing interventions, whether an older population is a focus. Again, sort of the media stereotype, what you tend to observe tends to be younger. Do any of you have in any of the work, Hannah, you mentioned it explicitly, but if any of the others of you disaggregated some of the data by age and whether you see different phenomena, different experiences along that spectrum?
I can start. We didn't disaggregate our data by age, but one thing that we did find, which I did think was interesting, and I think warrants further, investigation in our study, is that the group of unhoused veterans who were unhoused at the time of cancer diagnosis actually were diagnosed at a younger age than the housed their housed counterparts by about 5 years younger. The housed veterans had an average age at diagnosis of about 68, whereas the unhoused about 63 years old. And so I think that highlights some questions for me in terms of the impacts of housing instability and homelessness on people's health that might have impacts even down to the cellular level, beyond thinking about just things like access to care and all the important things that we're talking about here, but chronic weathering and the chronic stress and how that might play in. So I think that the aging of the unhoused population is certainly an important issue, and it might, show up in a variety of different ways when we're looking at diseases that we think are more commonly confined to older adults.
David, in the some of the trend analysis you presented, anything stand out there?
Well, it's interesting. I was going to chime in and say we didn't study that question. However, this is data, the point in time estimates from the continuum of care units, and obviously the death certificate data does in fact have measures across the age gradient and veteran status. And so anybody listening into the webinar, there's a ripe area for future research to be done. So I hope someone picks up the mantle.
Yeah, and I'll ask the same of Matt. And at the same time, a question came in from the audience. You referenced social housing, a term that maybe not everyone is familiar with. So if you could say a little bit about that. But I am curious also, you presented data on increases in mortality, and I just wondered if there was an age dimension to that.
Yeah, that's something we didn't specifically analyze. But when you look at kind of the average age of death, it ranges, I think the average is around 50 to 52, which is 20 years younger or more than the average life expectancy in the US. So, many of the medical conditions that people are facing, like diabetes, like cancers, are occurring 20 plus years earlier than they would among the general population. To the question about social housing, by that I mean housing that is permanently affordable and often is owned publicly, whether that's via various public corporations or the government itself or nonprofits. People have a stake in that housing and can live there for the long term at an affordable rate.
I do have to note in your first response that 20-year gap is not terribly different than the gap we saw in the first panel about the life expectancy in different neighborhoods within the same city. So if we needed any more evidence, which I don't think we do, about the critical role of living circumstances in health and life, and maybe in partial answer to the question of whether being unhoused is part of a continuum, we see housing effects for people who are fully housed. We see life expectancy effects for people who are fully housed, depending on where they live as well. So very different mechanics, different dimensions, but all playing out here. Well, thank you all. I know it was a lot to cover in one panel, but I think the breadth was a strength of the panel to show the critical multiple relationships and the importance to the healthcare sector of viewing people without housing at all as at very elevated risk of mortality and morbidity. And as we saw earlier today, some opportunities for the sector to intervene at the health level as well as at the housing level as discussed here. So appreciate the presentations here and the papers, and encourage our audience to look at the papers in full after the event. We're now going to